Good afternoon and welcome to Delivering Informed Care based on a longitudinal view of patient data, a health system CIO Media Inc. production sponsored by ELLKAY. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of Health System CIO and I'll be your moderator today. We're looking forward to your participation. You can use the questions and comments box at any time, and we'll take those later in the program. We're going to have a nice one-question poll that we put out, and we'll have our panelists guess at the results before we reveal them. So that's always a lot of fun. Nice way to view the screen today. Click on the top center, get it into side-by-side mode. Then you can adjust the divider to get the slides and the video boxes the size you like. And it should say speaker view in the top right-hand corner. Just so you see how we're going to spend our time today, we're going to go about 35-40 minutes with our panel discussion featuring Mariann Yeager, CEO of the Sequoia project, Mike Greiwe, Dr. Mike Greiwe, CEO of OrthoLive, and GP Singh, VP of Interoperability Solutions with ELLKAY. So let's jump right into our discussion. Mariann, let's start with you. Can you give us an overview of your organization and your role there?
Well, sure, Anthony, and thanks for inviting me to join today. So the Sequoia Project is a nonprofit with a public good mission, and our focus is very singular. It's really to advance secure, interoperable, and nationwide exchange of health information. And we do that by bringing together public and private stakeholders to work on key issues or challenges that impede interoperable health information exchange. And our focus is not so much on academic or standards or things of that nature, but we try to focus and hone in on the real practical implementation level issues that, really boots on the ground perspectives. That's really what we're all about.
Very good. Thank you, Mike.
Yeah, so I'm the CEO and founder of OrthoLive. I'm also a practicing orthopedic surgeon, and OrthoLive was really built to bring patients and providers together. It was a way to do telemedicine sort of before telemedicine was cool. So we started back in 2016, and our business really delivers a robust telemedicine and telecommunication platform to orthopedic groups. And to date, we've served thousands of patients, thousands of surgeons, and close to 1 million patients. So that's kind of what we do in a nutshell.
Very good. GP?
Yeah, hi. I'm the VP of Interoperability Solutions at ELLKAY. ELLKAY, as everybody knows, is known as the healthcare data plumber. We've been dealing with healthcare data even before data was sexy in the healthcare space. We've been in business for over 18 years, worked across a gamut of, across 5 segments of the healthcare domain, meaning labs. We worked with labs for a long time, and 9 of the 10 labs in the country work with us right now. And done a lot of work around the data archiving, data migration space, which really is the basis of our growth in the interoperability space. So we work with the labs, hospitals, with the ambulatory systems, with the payers, and with the vendors in the healthcare space.
All right, very good, Mike. We're going to start with you. How would you define the term longitudinal view when it comes to patient care? What does it include, and how is it different from the way care was delivered in the past?
Yeah, it's a really good question, Anthony. And we're talking about a longitudinal view today. And so for me, longitudinal view as it relates to patient care revolves really around the concept that patients' health history, their procedures, their medications, allergies, all of that, the whole medical history should really be transportable amongst healthcare providers and available to healthcare providers, really no matter where the patient is. And this idea, I think, helps providers sort of see the whole length of the patient's journey, not just kind of that snapshot that we get right now. And so, in the past, care was sort of delivered as that snapshot. And so if someone would come into the orthopedic office, we'd sort of understand what was going on with them right now, but we never really got into depth and detail about what was happening with that patient before. So, that's really what, to me, like that longitudinal view is seeing that whole patient journey and being able to have access to it immediately, with some of our data. So that to me, I think is what longitudinal view is.
Mike, there is something to be said for the right amount of data, right? Because we've heard from lots of physicians, they don't want everything. You know, when you talk about wearables and things that are constantly generating data, they don't want a big dump. So you want a longitudinal view, but you want to see the right things. So can you talk a little bit about that?
Yeah, I mean, as a surgeon, that is, you're hitting home with those comments, Anthony, really are, because, you know, I don't want information overload. I want to know what's important to me in that patient journey. So for me, it's really focusing on the things that we ask questions about, like the past medical history. I'd like to know what, you know, the patient's dealing with, but I don't need to know in detail, you know, what their blood pressure was on January 25th, 2015. So having that information in a more generalizable form of kind of their active problem list and what they've dealt with before, understanding what surgeries they had and exactly what was done, those are critical pieces to me. So, you know, there is a fine line, in, you know, in terms of the information we get, not that information overload, but really the finite piece of information that we truly need is critical. So you're hitting the nail on the head with that comment for sure.
Very good. GP?
Yeah, hi. Yeah, obviously we're dealing with the concept of longitudinal view even before, you know, it became such a big deal, but because, you know, data is fragmented, right, across all kinds of EMR systems, all kinds of labs, lab reports, imaging data that's out there. And what we've seen is the need for us to be able to kind of help bring all of this data together in a clean way, so that, you know, because obviously you mentioned about the fact that there's a lot of data, but there's a lot of bad data also, and being able to, you know, really provide a clean view across the entire patient journey is what is important. Bringing in all the active meds, allergies, problem lists, but also the historical information from the labs, the imaging is actually very critical in that sense. We've recently seen a growth in terms of the number of organizations that have basically said, look, you know, we are a large healthcare system, but the hospital EMR is a different EMR, and then the ambulatory side is a different EMR, and the practice managers or the practitioners in the ambulatory space really don't get to see what's happening on the acute side. And if a patient lands up on the acute side, they don't, the practitioners over there don't necessarily get to see the data from the primary care or the specialist. So our, you know, focus has been around trying to generate a holistic view so that wherever the patient goes, you know, the data kind of flows along and is visible at all times to really help with better care.
And GP, you know, you talked about how even within a health system, especially one that's grown through acquisition and whatnot, there can be a lot of isolated silos of data, and that gets people
Right.
certainly frustrated, right? Because if you've got the same name on the physician practice in the hospital, the expectation is that there's interoperability, as opposed to maybe if you're at two different organizations, you say, okay, I get it. So organizations that are of one unit, they need to go even more out of their way to get this done, because they're not meeting the expectations. Does that make sense?
Yeah, absolutely. I mean, that's a major issue is, you know, and Mark Probst, our new CIO who just came in from Intermountain Healthcare, talks about the fact that, look, you know, he's been in hospital systems and dealt with a lot of these, and it's interesting how they're not as connected as they need to be. And that really creates a lot of frustration within the provider base, but also within the patient, right? Because the patient's always worried about whether their information is actually flowing the right way or not, and do they have access to all of that holistic information or not? So yes, that is a big pain point.
Mariann, what are your thoughts?
Well, you know, for all of that to be possible and to support longitudinal patient records, you really have to be able to access data across multiple sources, and typically, as GP was noting, disparate systems. And, you know, more importantly, the data itself has to be semantically interoperable. And so for all of that to really work and for the information really to be usable. And so from where we sit, you know, those are really the two key building blocks: is how do you enable that more readily, and then how do you make the data usable? Even though we're more interconnected than we've ever been as a country, you know, one of the big issues is how do you make the data usable to clinicians in particular.
Very good. Well, we'll talk more about that. We'll get into more detail. And let's start with that. GP, what are the challenges around presenting a longitudinal view and why is it so difficult?
Well, traditionally the EMRs were not as open, in that sense, and that seemed like quite a bit of a roadblock in terms of being able to access data out of the EMRs. But then also what we're really seeing now is the fact that, yes, there is a lot more plumbing in place than before. But then the quality of data that's flowing across that plumbing is not necessarily, at par, because there's a lot of unstructured data that's sitting in there. There's a lot of duplicate data that's sitting in there. There's a lot of data that, organizations have to figure out a way to reconcile, deduplicate, have, EMPIs in place to be able to, really manage all of that, and then ensure going forward, that clean data continues along. One other big factor that we're seeing out there is the fact that there's a lot of unstructured data that's really not being handled as effectively. It's one thing to have discrete data, but then it's another thing to have a lot of unstructured data. And there's a lot of information in that unstructured data. So that's a major challenge that I think is going to become acute at some point in time, because as more analytics platforms come along, as more pop health programs become available across, as people are trying to get into clinical decision support systems and things like that, that unstructured data is going to become extremely valuable, and being able to, really get that data and make that data available in a discretized format is going to be really important. So that is a major challenge.
A couple of things there. So one issue, which is its own issue, could be sort of bad data from the beginning, meaning data is being put in incorrectly or a variety of formats or something within an organization. And that could be a data governance issue, right? That they got to fix that just to get the data right. That's separate from the issue of a data in Epic versus data in Cerner, and they can't, right? Two separate issues, correct?
Yes, absolutely. I mean, one issue is the fact that, okay, having a free flow of data between systems and being able to reconcile that. The other issue is obviously the fact that, what is the quality of data, and then how do you actually reconcile across the quality of data? So I think both of these are challenges when it comes to interoperability. My wife is a primary care physician, and when she sees patients, she'll see, handwritten notes in the chart that have been scanned, or some sort of Mike is smiling over there. I'm sure, Mike, you know what I'm talking about.
Absolutely.
Because that's her frustration. That's her frustration out there trying to, figure out how can she get a holistic view of a patient when some of this data isn't necessarily in the right format. But obviously, the first step is establishing the plumbing. The next step is to go ahead and then work on the data quality and really being able to extract good data out of these, unstructured data elements.
Wow, that's a lot going on there. Mariann, your thoughts?
Really just echoing what GP said, and then from where we sit in particular, that's really where our focus has been, is really how to enable systems to interconnect and enable the exchange of information, which is very much akin to plumbing. And then really the focus right now for us, and what we think we need to do to double down on that, is to focus on the semantics of the data being exchanged so that it can be usable, and then also, of course, data quality being a separate but important issue. I think there's going to be a lot of agreement among this group here, but those are really the two core challenges and the two core needs to make this viable.
Very good. Mike?
Yeah, I would also echo what GP said. I think, as you look at the way, finally, or at least getting this data to be electronic, right? So first of all, it was all written notes. And you look at the evolution of how this really has occurred is you had notes that were written. Those notes then sort of became part of the EHR, as we scanned them in and things like that. So you had this massive amount of unstructured data. Now we're actually creating discrete data. What that means by discrete data is just, data says, this patient has hypertension, and that discrete data then lives in the chart and can be passed on. But, when you just scan a record, there's no information there. There's no actual full, data. You don't learn anything or achieve anything by that, and you can't pass it on. And now we're also dealing with the fact that there's multiple EHR systems out there. So because of that, now we have unstructured data, we have multiple EHR systems, and we have, I think, a challenge, in moving all this data to discrete data and then moving forward. So it's this constant, I think, evolution that's happening. I think it will happen, but it's obviously, we're having to undo a lot of the past to try to get forward in the future. And it's happening. It's just, it's moving slowly.
Very good. All right, next question. We'll start with you, Mariann. What are the major advances that have been made on the interoperability front in the last 12 months or so? Doesn't have to be perfect. What achievements do you anticipate being made in the near future?
Well, I would say there's been really significant progress, particularly in the private sector, in growth of health information network connectivity. So more and more providers are connected to, more and more providers across the continuum of care, for instance, are connected to health information networks, which is important. I mean, the first thing, to make interoperability a reality is providers actually have to be connected to networks and have the ability to share information with others. And so we've seen that now that there's been really a monument growth in the exchange of information between and among health information networks. This was evidenced by Care Equality, which really provides a framework and a standardized way for health information networks to interconnect they basically agree to share information according to a particular set of standards and implementation guides, and they all agree to exchange under a set of policies and terms. And so just to share some real world numbers, they've had more than 1 billion with a B clinical documents shared over the past several years, with the lion's share of that occurring over the past 12 months. And so we're just seeing exponential growth in that area. I think, the interesting thing is, what achievements do we anticipate in the near future? I think we're going to just continue seeing unprecedented volumes and growth and information being shared and increased reliance on providers. But I think with that are going to come some increased frustration that if the data being exchanged is not usable or valuable to clinicians, then that just escalates the pain points that already exist. And for us, that's a call to action in terms of what we need to do to improve. And that's really, again, focusing in on the data.
Very good, Mike.
Yeah, I mean, I think the main thing for us to focus on, is the fact that telemedicine and sort of the COVID outbreak has really changed the way that, private companies view the healthcare landscape. And so they're feeling like, now is the time for technology. And I think they're pushing harder than ever to comply with interoperability and comply with interoperability rules and do the things that are necessary to make sure that we achieve this interoperable landscape. And, it started pre-COVID with, HL7 Fire, which is kind of a nice shareable information source. And I think it's just going to continue to build, and we're going to see even better interoperability in the future. And so I think just like everything else tech related, there was a huge push that happened through the COVID crisis. And I think it'll be there in the future as well.
Very good. GP?
Yeah. So one of the things that's happened in the last 12 months, I mean, FHIR has been around for a long duration of time, right? And everybody was hoping for FHIR to get on fire, but that wasn't necessarily happening. And I think in the last 12 months, there's been a significant, difference in that sense. We see a lot of organizations talking to us, wanting to, work with FHIR and want to enable features out of FHIR to really become more interoperable. So that's one thing that's definitely out there. That's really helping, that people are catching on to a single standard of exchanging data. We're still a long ways away from getting to where the ideal state would be, but there's definite push in that sense. I think the other thing that's happened in the last 12 months, especially with the last 6 months, which have been really interesting, right? People have recognized the fact that, interoperability is no longer optional. It's actually, right here, right now, we need, and everybody needs to be able to be interoperable if they're going to be able to function. And that's been a big difference in the last 6 months. We're actually seeing organizations that are coming to us and talking to us about figuring out a way to become interoperable, to be able to have multiple systems be able to talk to each other. And I think they're now making a commitment that we didn't see at this level before. Telemedicine, as Mike pointed out, is an interesting area. Everybody is so excited about telemedicine, but then we're seeing pain points around the fact that telemedicine is introducing another area of interoperability issues because a lot of data is sitting in telemedicine platforms that not necessarily making it back properly into EMRs because of the rush to go ahead and get telemedicine platforms up and running. So that's another area that I think is going to improve in the near future, where telemedicine platforms will need to figure out a way to be more interoperable, where they're getting a lot more data into the platform, but then also being able to send data back into the source of truth, which is still the EMR.
GP, you mentioned that this could be because of the rush to get the telemedicine platforms in. How could it have been done better so there would be more interoperability if there had been more time?
Yeah, it's an interesting question, right? Telemedicine platforms have been there for a while. It's not something that just recently came about. And Mike will tell you, he's been in that space for a little while, just as a lot of other organizations. But the adoption wasn't there from a patient perspective, and that's the area that got forced, during the COVID times. There was some sort of a mental block around using telemedicine platforms face-to-face with it. Just was a traditional mechanism, and patients and providers felt better doing that. But I think the last 6 months have kind of shown the fact that telemedicine visits are equally important and equally play a really good role in helping the patient-provider relationship and being able to have access to care. So the last 6 months, there was no way you could have avoided the rush. You needed some sort of a push, and this was unfortunately the push in this situation. But I think we're now at a point where both sides, the provider and the patients, are feeling more comfortable. My wife's using telemedicine, and I see her working harder because her nurses, her appointment staff, her billers are working extra trying to reconcile information across the telemedicine platform and the EMR.
All right, very good. Mike, to you, what can you tell us about your interoperability journey at OrthoLive, and what were some of the main challenges and how were they approached?
It's a good question, Anthony. We, as a surgeon sort of designing the platform, I knew that interoperability was important. So anything that kind of comes off of our platform is HL7 Fire. But that doesn't mean that all the other systems and all the other programs that we work with and the EHRs that we work with work off of HL7 Fire. So we have actually, worked to try to, make sure that that information can be spread across the institutions as well. But, there are two main issues. The first is scheduling. So, just that first challenge is when you come into our platform and you schedule an appointment, how is that information going to get over to the practice management system? And so that's where we sort of turned to ELLKAY to sort of help us to understand that and to make sure that that came across. Because what's happening is, because we've had to schedule so many telemedicine appointments in the COVID time and even after, healthcare practices are actually employing a full-time person to do telemedicine scheduling. And that is a gigantic waste of time when that information should just automatically sort of populate in the PM system. So OrthoLive kind of decided way ahead of time that this was a very important thing that we needed to do to save, healthcare practices time and money by making sure that information flowed across. And then there's other things like past medical history, allergies, medications, changes to patients' health status that also needs to feed across to the EHR. And it's all things that telemedicine companies collect, but currently do not send across. And again, that was something that we have worked on with our partners at ELLKAY to make sure that is happening. And we've been very, very happy with that. So, those were the main challenges, I think, is making sure scheduling and the information that we collect gets across in a seamless way. Otherwise, people are wasting time doing things twice and having to re-enter information.
So, Mike, you're a surgeon, right? You're a CEO. You seem like a pretty smart guy. Did you consider trying to do this stuff yourself in-house, bring on a CIO? You seem like you know a lot. What is this just beyond the ability of, I don't know, individuals to do, so to speak, and you need a company like ELLKAY? Is it just too complicated?
Yeah, I mean, honestly, if you want to work with everybody, you need to work with the experts that do interoperability, right? I mean, that is the bottom line. You can't, as a single institution with a single person, you can't reach all of the different information sources. So like, you can work off of HL7, you could work off of HL7 Fire, you could have, specific, sources of information that comes across. And to already have those relationships built, to already know that ELLKAY already works with Epic and Cerner and all the different, EHR, major EHRs and the small ones too. We knew we needed kind of the experts to handle that. And our team, was not going to be able to, and nor do we want to spend our resources trying to hunt down those things. So, for people that need interoperability, you turn to an expert to make sure that it happens properly. And that's what we did.
Very good. All right. Next question. We're going to start with you, GP. How has the COVID-19 pandemic affected the march towards interoperability? Was it a speed bump or did it speed things up? It sounds like from what you were saying before, you think it sped things up. Is that correct? Or at least it sped up the need for interoperability and the understanding for that need.
Yeah, absolutely. I think the COVID-19 pandemic has really, helped organizations to actually, not necessarily help, but really see the fact that those gaps in care, being able to send data around test results, for example, lab results is a major pain point that's not being addressed. So a lot of organizations seem to be, now understanding or at least making a commitment, to really making interoperability happen. One of the things I do want to point out, Care Equality and Commonwealth, these two platforms have played a major role while all of these organizations are trying to bring data across, the various clinical entities, across the healthcare system. And that's been extremely helpful. We work with both of them, and that's a lot more healthcare systems are relying on data out of Care Equality and Commonwealth, which is a really important step. But then also the fact that there's still a lot of data that's not necessarily connected into Care Equality and Commonwealth, and they're trying to figure out a way to handle that information. I remember getting a call from a hospital basically saying, hey, guys, help us, because we've got all of this data and all of these state agencies and these public reporting agencies need a lot of that data, and we're not able to give it to them right now. We need some mechanism to go ahead and bring all of this data together and then provide an API or some other mechanism to be able to provide that data to whoever needs to consume that data. So we're seeing those situations on a regular basis now. So it's definitely moved things faster or better in a better way from an interoperability perspective.
Very good, Mariann.
Well, we definitely saw COVID. It has been serving as an accelerant. There is sort of a shared call to action to really do everything that's humanly possible to make information available, particularly to public health. And you really, in the midst of any emergency and particularly a pandemic, trying to build something new is just not necessarily practicable. It's definitely not expedient. So we saw that there, really was a need to leverage existing infrastructure. And so we saw, in a very short period of time, folks that were sort of on the sidelines or, sort of had that connecting to care equality or connecting to a health information network was on their radar, that they sort of, all of a sudden there was this impetus to really move more quickly. And anytime that happens, we also uncovered some challenges from a policy perspective, which is where Sequoia is focused, in that their providers in some instances are very reluctant to share information with public health for pandemic response because they're worried they might be sharing too much information. CCDs, for instance, have a plethora of data, a ton of data, and there were concerns that they'll be violating HIPAA minimum necessary. So we've been actually working with HHS and the Office of Civil Rights to issue guidance on this because it's not necessarily technical impediments to making that possible, but sometimes it's the policy. So,
Excellent point. Mike?
Yeah, I think what we saw from a telemedicine perspective is that we were able to offer a significant advantage over other telemedicine platforms that did not have interoperability. So we saw people coming to the platform looking for that. And so I've seen, you know, the COVID pandemic really increase people's idea that you know, it's important to share data. It's important to make sure that, you know, we're not as healthcare practitioners wasting time trying to get information from one source to another, that it just flows automatically. So I think telemedicine to me has really highlighted how important it is to have shared data and have interoperability. And COVID was really the impetus for telemedicine to be adopted in the US, as GPs mentioned earlier. And so now I feel like we are seeing more of that desire for interoperability, at least in our area of expertise.
Very good. Mariann, anything else you want to tell us about what the Sequoia project is working on?
well, our work falls into two categories. It's what we do through our Interoperability Matters program. So we've been focusing on information blocking compliance and emergency preparedness. And we have a new group, a work group that's focused on, that we're preparing to launch, that'll focus on semantic interoperability as it relates to data content. And then our work on the government side is our work with the ONC supporting their Trusted Exchange Framework or Common Agreement or TEFCA. And that's really a government endorsed approach for information sharing that's really exciting, has true potential. So we have our hands full, we're very busy, you know, again, keeping our boots on the ground focused, and then of course, looking ahead to government sponsored activities.
Very good. All right, GP, let's start with you here. What's your advice for organizations looking to improve their ability to move data from one vendor's application to a different vendor's application? Of course, there's the call ELLKAY joke we can make, but what can you tell them to do? What's sort of the basic first steps?
You know, the most important step for an organization is really upper management buy-in and a vision for the organization, and not really taking a piecemeal approach, but having a holistic view of how the organization is going to handle interoperability, not just for certain segments of the care, but across the entire you know, healthcare system. So really, you know, the advice for an organization is really making sure that the upper management buy-in, focus, vision is in place to be able to do that. And then, of course, working with subject matter experts that understand how to go about this and helping implement that vision is really important from that perspective. A lot of the EMR systems or, you know, moving data from one vendor to another vendor requires, you know, it's supposed to work to a standard, but that we're still a long ways away from that. There are certain capabilities and certain things that aren't necessarily available, you know, from that perspective. So be aware of that and make sure, you know, to plan for things from that perspective. But most importantly, have a vision, a commitment to make this happen.
Very good, Mike.
Yeah, I think, you know, making sure that you have an internal champion is really key. Having somebody that actually does, you know, decide like this is their main job, this is their main focus, and they want to take the data from one application to the next. It's very important because if you don't have a champion internally, it is hard to make change happen, especially inside of healthcare. I think it goes for telemedicine to, you know, mobilizing data from one system to the next. So that's probably my primary recommendation, is that, you know, there be a champion, they follow a process and work on things that way. That's probably the best advice I can give.
All right, very good. We're going to put out our audience poll now. So go ahead and answer that, and our panelists can as well. I think I know how they're going to answer it. I think I know how this survey is going to go. I try and think of things where there'll be an interesting balance, but maybe I messed up here. The COVID pandemic will prove to have been a catalyst that propelled interoperability forward. So go ahead and answer that, and we will, oh, this is getting interesting. we'll take a look at the results. So if everybody can answer that, I would very much appreciate it. So while we are looking at that, we're going to go to our Ask a Co-Panelist segment. GP, do you have a question for one or both of your co-panelists?
Yeah, actually, Mariann, have a question for you in terms of, where do you see interoperability, specifically with care equality and Sequoia taking such an important role? How do you see data being shared, or what challenges do you see in that space around sharing data?
Well, I think that there's going to be continued momentum in sharing information, across health information networks through private sector approaches like care equality and potentially, with TEFCA being a government endorsed approach. I think that it's going to, what we're seeing is it'll definitely be an expansion of expanding this frameworks to also support FHIR-based exchange and other use cases beyond basic treatment. And again, having that common underpinning instead of having a specialty network or a specialty framework just for treatment, that we'll see that multi-purpose utility used for many purposes, hopefully public health more expansively, and then of course expanding it to support other approaches like FHIR-based exchange. We really think that's where it's going, and again, having that core infrastructure built from.
Yeah, so just a follow-on question on that, Mariann, just trying to understand, with the interoperability guidelines from CMS and, payer APIs and, patient access APIs and things like that, do you see you guys, is Sequoia and care equality going to play a role in making that happen, or, at least some sort of a vision around that?
I think care equality will certainly look at that operationally speaking, and they're already working and have adopted, a new use case around FHIR-based exchange. They are working now on a white paper to explore how that intersects with and what the opportunities are to support the interoperability requirements under the CMS interoperability rules, and of course, the payer API approaches. So I think care equality has a clear roadmap in that space, and sort of, being the intersection with that. From where we stand at Sequoia, broadly speaking, we really are looking at things in terms of sort of national level roadmap, a coordinated implementation plan, particularly when as it pertains to really the semantic interoperability and how you get the requirements fine-tuned and the vendors, sort of in lockstep on, a roadmap that can iterate over time and to really, again, improve the semantics of the data being exchanged.
Thank you.
All right, we're ready to look at our polls. So let's get our panelists to guess at the results. What percentage do you think agree with this, Mike?
Well, the people that are on this, I would imagine probably at least 97%. That's my number. I'm going with 97. 97, GP.
I'm going with 92.
92, Mariann.
I'm a little more circumspect. I'm going to say 80%.
80%. All right, and the answer is 89%. 89.
Okay.
So that is
GP is the winner.
He is.
Yeah. GP, you'll be sent a prize in the mail. Okay. So
I'm looking forward to it.
Yeah, it's going to be very exciting. All right. We have a couple of audience questions I want to put in front of you. Let me start with you on this, GP. How do you convince clients of the value of data governance?
That's an interesting question. One of the things is, we've got a lot of experience, right, doing this across so many organizations out there, and what we've seen around the way to kind of talk about this is being able to bring those experiences to these clients or these prospects that are talking to us, where we talk through all of that and make sure that they're aware of the importance of data governance, the importance of really making that a priority in that sense, and there are use cases that we've seen, there are success stories that we've seen. So we bring that out there to be able to use that to convince folks. We've got an advisory panel at ELLKAY that's the who's who of the healthcare systems, and who talk regularly on these subjects. So it's something that people trust us and value our opinion in that sense.
Mike, do you have any thoughts on that? Do you ever have to be in a position to convince people of the value of creating good data?
Well, I am also a researcher, and so from my perspective, good data is probably the key. I mean, it is really what research lives and dies on. And essentially, we have a saying in research that's sort of like crap in equals crap out, and that revolves around the data. So if the data is no good,
Right.
then you don't get the right thing in the end. And so it is. I could give a 30-minute talk on how important good data is on the front end, right now. And so to me, I spend a lot of time convincing researchers, convincing institutions that the data that they receive, and then when they churn that data and they put it through their algorithms to figure out maybe what risk a patient is for having a total knee replacement to come back to the hospital, if they don't have good data coming in to understand what their past medical history is or whatever, we don't get the answer coming out. So it is very, very important. And, so I do spend some time talking about that.
Very good.
One of the other things that
go ahead,
one of
GP.
the other things I'm gonna add on that is data governance. Better data governance is equal to better revenue. And which really means that better data is going to help with better care. It's going to help with decreased costs along the way, and then improved capabilities and revenue across your pop health programs and analytics platforms and things like that. So the quality of data is absolutely important.
Very good. All right, Mariann, do you happen to have a question for one or both of your co-panelists?
Well, given that GP's focus is really very knee-deep, steeped in interconnecting systems, and you probably live and breathe firsthand all the challenges around that. What do you think could be done to improve interoperability, at least to make it easier, your job easier?
Yeah. Well, the more challenging the job, the better we get paid, right? So, no, I'm just joking. But I think like I said before, right? Data quality is important, but really a commitment at the CIO level, a commitment at the management level to really making this happen, seeing the value downstream. Improving the patient experience, improving the provider experience, these are all key important areas, right? In that sense, honestly, I feel sad for the providers right now. I feel sad for the patients right now, because providers are overwhelmed with a lot of information, a lot of data. They see patients for about 6 or 7 hours a day, but then spend about 2 to 3 hours, charting. That's a major pain point for them. So, if there's a way to kind of manage that, and so that they're not scrambling for data or trying to understand what happened with the cardiologist, a primary care physician isn't working on that's going to help their lives. So that, so I feel like, there's got to be a commitment around changing the old order and really trying to move towards an order of organized, data governance, but also, systems that help the providers really do a better job and improving efficiencies. On the other end is also the fact that there's frustration on the patient side, because they don't necessarily feel like they're at the center of care, and making data available. And that's what this, initiative from CMS is around, having patient at the center of the care, making sure that the patient has access to their own data, which has been a tough thing to do. And now having to work with those mandates is going to mean that, a lot of these organizations are going to pay attention to that, which will really help them downstream, significantly.
Very good, Mike.
So that'll make our life a lot easier.
Very good. Very good. Mike, do you have a question for your co-panelists?
Yeah, I mean, Mariann's sort of the person who has kind of this overarching understanding maybe of where interoperability is in terms of the healthcare landscape. I'm curious, Mariann, how long do you think before we actually can do this for our patients, that we have this, interoperability figured out? I mean, what's the time frame going to look like? And obviously it's a moving target, and it's certainly a slow evolution, but I'm curious what your thoughts are in terms of solving this issue and how long that's going to take.
Oh boy, I think it's going to be a lifetime evolution, but I think we're going to see substantive progress in probably about 5 years. I know Congress and policymakers want progress immediately, and naturally that was the impetus for what 21st Century Cures and the subsequent rules that were published by CMS and ONC, making it illegal now to not share information unless you have a valid reason not to. But I think practically speaking, to work through and mature all this, I think it's going to be a good 5 years. But I think by then we'll see some real progress day to day for us as individuals. That's it. My litmus test is when I go to the doctor, I take my kids to the doctor. I'd like to see this in real practice and
absolutely
snippets,
Yeah. I mean, do you think that that time frame, are there going to be, CMS is going to be sort of rewarding people for having interoperability and penalizing people for not having interoperability?
Right. Yeah.
Exactly.
I think it's, the nudging and the carrots and lever, and the carrots and sticks are going to be, unfortunately, part of the equation. You wish it wasn't necessary, but it's going to take all of these factors. And plus the motivation. I think COVID is a great example of there's a real desire and passion to make all this work. And sometimes having a shared goal, is enough to push it to that next level.
Yeah.
All right, very good. We're almost out of time, but I want to give GP a final chance to give a last word to the audience. Some thoughts and advice. I think Mike got scared when Mariann said 5 years. He didn't look happy about that. But we also have Mike talking about HL7, which is great to hear a CEO talking about HL7. So GP, your final thoughts and words of wisdom for the audience today.
Yeah, no. So, I think, COVID-19 has really been a good example of, what happens when people get together and they're motivated to take care of things for the greater good. I strongly believe in the fact that, healthcare professionals are all motivated for the greater, care and providing better care and taking care of their patients, providing improved efficiencies out there. I think it's time for the organizations around these providers and patients really to, take it to the next level. Obviously the status quo is not going to, work. It's important for everybody to treat this as an important priority for 2021 for sure, so that God forbid, the next time something like this happens, the healthcare organizations will be in a better place to be able to handle that, won't have to scramble the way they, unfortunately had to. So I think, there is enough reason to get the job done. There's enough reason to be able to focus on longitudinal patient record, single patient, single record kind of a concept that's really important. And I don't think, I would definitely, advise professionals out there to not lose momentum when this goes away, to keep that momentum moving forward and hopefully achieve that larger, greater goal.
Well, very good. You get to see it firsthand, right? With your wife, you get to see the effects of either good interoperability or not good interoperability. So of what
especially when she's working from home.
That's right.
Exactly.
That's right. Make your own dinner, right? Because she's working. Yep. We know how that goes. Very good. All right. Well, that was wonderful. Regarding continuing education, you can use the final slide in this deck. You'll get an email when the on-demand recording is ready. If you want to sponsor an event with us, you can contact Nancy Wilcox from our team, and you can go to our website to register for our upcoming webinars. With that, I want to very much thank our panel. It was a delightful conversation. Mariann Yeager, Mike Greiwe, GP Singh. And I want to thank our sponsor, ELLKAY, for making this discussion possible, and thank you for attending. And with that, everybody have a wonderful day. Thank you.